to Dialogue Across Difference, an event series hosted by the Centre for the Study of Politics and Governance at the University of Minnesota's Humphrey School of Public Affairs. Join us as Centre Director Larry Jacobs and guests engage in conversations across the political and policy spectrum on issues of the day.
All right. Good morning, everybody. Thank you for coming to this morning's event. And I know there's a very large online audience as well. I think we have close to 300 that are registered online for the virtual component of this, and there'll be a recording afterwards as well. I'm Lynn Nelson, Vice President of Public Affairs at Blue Cross Blue Shield in Minnesota, and Blue Cross is a proud sponsor of this important and timely public event at the University of Minnesota Center for Study of Politics and Governance at the Humphrey School of Public Affairs. For more than 90 years, Blue Cross has supported the health and well-being and peace of mind of our members by striving to ensure affordable and equitable healthcare access to all. As Minnesota's first health plan, we have a strong history with Minnesota healthcare programs, including Medicaid and with government agencies that support them. We believe that our mission and values as a nonprofit health plan align well with the goals and needs of the Medicaid population and how we bring value to our public program members through quality, innovation, and community engagement. Paving the way for everyone to achieve their healthiest life is the mission of Blue Cross. An unwavering commitment to this mission has earned Blue Cross the highest ranking in trust consecutively for more than a decade and ranked insurer of choice 3 times more than any other insurer in Minnesota. Since the inception of our nonprofit subsidiary Blue Plus in 1974, Blue Cross has offered members eligible for one of Minnesota's healthcare programs, including Families and Children, Medicaid, Minnesota Care, and Medicare and Medicaid integrated plans. Blue Plus is a managed care organization that is focused on ensuring that Minnesota's Medicaid members get care where they are, serving locally in all 87 counties. Members receive person-centered care through tailored benefits and services that address health and wellness. Blue Plus collaborates with counties and community organizations to improve access to services, and we align our goals with the Minnesota Department of Human Services to promote health, fuller lives, and lower costs to Minnesotans. Blue Plus, Medicaid, and Minnesota Care members have access to a broad network of statewide providers, ensuring accessibility for members whether they live in urban, suburban, or rural communities. Blue Cross offers care coordination, transportation, and improved dental care for members. Blue Cross is working towards making our communities healthier by partnering with Minnesota nonprofits, promoting racial health equity, and supporting charities. This mission of Blue Cross to pave the way for everyone makes the topic of managing Medicaid important for all Minnesotans. Blue Cross believes that managed care organizations like Blue Plus bring crucial assets to the managing of Medicaid. I mentioned the ease of quality healthcare for Blue Plus members earlier, but all Minnesotans benefit from the budget predictability and accountability that managed care organizations like Blue Cross bring to the state healthcare programs. In a managed care payment system like public programs, prepaid health plans like Blue Plus take the risk so the state can set a healthcare budget and stick to it. This provides the state a level of budget predictability. Blue Cross has earned trust with members and county partners by demonstrating a high level of accountability and transparency with all of its programs. Blue Plus and all managed care organizations are required to protect Medicaid from unexpected costs by ensuring that funds go directly into patient care or system quality improvements. In addition, Blue Cross submits reports weekly, monthly, and annually to the Department of Human Services and has a commitment to the program integrity, reducing fraud, waste, and abuse, championed in departments across the organization. Managed care organizations like Blue Plus bring crucial assets to the management of Minnesota healthcare programs, including advocating for our members through ease of access of quality healthcare, budget predictability, and accountability. Blue Cross acknowledges the challenges and opportunities of serving a diverse and complex population in a rapidly changing healthcare environment. We are committed to working collaboratively with the state, providers, and other stakeholders to improve health outcomes and reduce disparities. I thank you for being here for this important conversation of the role of Blue Cross and other managed care organizations in Minnesota, and to advocate for policies that promote health, fuller lives, and lower costs for all Minnesotans. Together, we can pave the way to the health of everyone. And now I will turn it over to Professor Larry Jacobs, the director of the Center for the Study of Politics and Governance here at the Humphrey School.
Thank you, Lynn Nelson. So I want to welcome everybody here and then folks who are joining us online to today's conversation, Managing Medicaid and the Debate at the Capitol. Before we begin, I want to welcome everybody, those here and those online, to participate. And for those of you who are online, you will see there's a Q&A button at the bottom of your screen. Click on that and send us your questions. We are printing them out. The printers are fired up and ready to get those. And we really count on everybody's questions. And we encourage challenging questions. And we'll try to get to as many of the questions as possible. Also, for those of you joining online, please note there's the option for live transcript. If you'd like that service, just click on that button and it's there for you. Before we jump into today's conversation, I want to welcome our two out-of-town guests, beginning with Scott Leitz. Scott has been working in health policy for over 25 years. He's now vice president of the healthcare programs department at NORC, which is at the University of Chicago. It is a renowned research center, and Scott's doing important work, which we will get to and talk about. But I also have to say that Scott is well known to many of us here in Minnesota because of his really legendary role. Here he was the CEO of MNsure, which is Minnesota's state health insurance marketplace. And this was not an easy time that Scott came on board. He was the guy that stabilized that program and has played such a key role in having the launch that it enjoys today as enrollment continues to expand. He also oversaw the establishment and implementation of the program in subsequent years. He became the Medicaid director here in Minnesota and was the assistant commissioner for healthcare at Minnesota's Department of Human Services. So Scott, big national guy and also knows Minnesota very well. Thanks for coming, Scott.
Thanks, Larry. Thanks for the invitation.
Andy Schneider is a legendary figure to those of us who follow health policy nationally. He's currently at the Georgetown University McCourt School of Public Policy. He's been active in health policy for over 40 years. And this is someone who has kind of worked the gamut. He worked in Congress as a high-level staffer. He worked in the executive branch during the Obama administration. He's been a private consultant. He's been a public interest attorney, and now he's a researcher at Georgetown. Andy, thanks so much for joining us.
Thanks for having me.
So Andy, I want to start with you. If you kind of go back to the beginning of Medicaid in the mid-1960s, basically a decade later, a dozen years later, costs are really rising fast. By 1976 to 81, costs are up 15%. A decade later, they're up over 25%. Why did that happen?
Well, different people will have different theories of this. You know, my personal theory is, number one, the delivery system was very inefficient at the time. It's a very different world than we've got now. Secondly, you had basically a fee-for-service mindset on the part of providers, on the part of payers.
So I'm just going to stop you there because there are people here and folks online who are not, you know, health policy lifers.
Yes.
And
Sorry.
and those of you who are lifers, I want to welcome you. I'm one too, but fee for service is not.
Fee-for-service, yeah.
Yes.
Fair question. And I will try to avoid that in the future. So fee-for-service is a system under which when a provider, a hospital, a physician, a clinic furnishes a service, a payment is made for the service. The more services the hospital, clinic, or physician provides, the more payments are made to the hospital. You can see where the incentives fall under that system. There's still a lot of fee-for-service medicine being practiced today, but to the point of what is driving cost inflation in the 60s and 70s, one of the culprits is widespread fee-for-service.
And so then there's a response. We see the federal government and states kind of looking at waivers as an opportunity to experiment. And then as you move into the early 90s, there's real concern. Wait a second, we got to get control over spending. The federal government starts to really crack down on how much they're going to allow the spending and Medicaid to go up. And they also say to the states, you want to experiment with other ways to deliver and pay for care? Go ahead. You don't need to come to us for a waiver. Go do it. How does that start to play out as you look at the 90s and the years after?
So that's a freighted question. There are lots of moving pieces there. Can I take a minute and start back a little further? Is that all right? So Medicaid, it's a federal state program. States can participate if they want to. All states have done so since 1982. And if they participate, they are entitled to have allowable expenditures that they make buying healthcare services or long-term care services for individuals who are eligible for the program. They're entitled to have that matched by the federal government at a specific rate, anywhere from 50 to 82%, depending on the population. It can be as high as 90%. The basic point is the federal government sets some broad rules, and within those rules, the states have considerable latitude to administer their programs. So the word waiver. There are some rules that accompany federal dollars that state administrators may feel are inhibiting their ability to innovate. At that point, they can go to the federal government and say, please waive these rules. In our case, don't apply them to us as we administer our program.
That's you, my friend.
It's me? I'm so sorry.
Silence your phone.
I'm very sorry. Nobody ever calls me. Let's just start with that. And of course, it's a phantom call. I'm sorry, this would have been off. All right. That was embarrassing. Let's try this again. So I had a nice narrative going.
Yeah, it was about waivers.
Yeah, so waivers, so don't apply these rules to me and let me innovate. Okay. So those are fundamentals. So we have this explosion in costs. States are struggling to maintain their spending for Medicaid in the face of healthcare inflation in the 70s and 80s. And there is some demonstration activity going on using various waivers in the 80s. We can come back to how we got there if you're interested. But among the demonstrations was, what did I just do? Okay, among the demonstrations going on here in Minnesota, there was one in Itasca County in, I think, 1985. There were two in Hennepin and Dakota counties. These were managed care demonstrations. Okay, managed care, not fee for service. You're paying a provider or an organization a fixed amount upfront every month to provide a defined set of benefits to the enrollees. And that's what the provider, to oversimplify, has to work with to provide the services that the provider or the organization is expected to furnish. Right? Very different incentive than under fee for service, because now you're rewarded as a provider or an organization for not providing services, because that way there's more left over from the monthly payment that you're getting. Okay, oversimplified. So, so those counties start demonstrating with federal and state Medicaid dollars a prepaid form of delivering services. And I don't know how that's played out. Since then, Minnesota was one of the early demonstrator, early adopter, early innovator states in the 80s, looking for ways to address healthcare cost inflation through these demonstrations. And it wasn't the only state, but there weren't that many. So I personally view it as an innovator. And those demonstrations, you know, fast forwarding, have led to the world we live in now in 41 states throughout the country, including DC. Those of us from DC consider ourselves a state. We're not. The driving force of that has been underlying everything has been an interest on the part of state officials. You do not have to purchase services on a managed care basis, but most of them have chosen to do so because they like the predictability of the expenditure. You know, in a prepayment, in a managed care environment, you know what you're paying each month. It might be the right amount, it might be the wrong amount, but you know what it is, right? And now all you have to worry about is how many people are eligible. And you have some policy leverage that you can calibrate to adjust that. But if you're interested in budget control, and many state officials are, then the predictability of the per member per month capitation managed care payment, that is an important budget control mechanism. And I think that underlies a lot of the trends that you've seen.
So this is a very fundamental point. You know, beginning soon after Medicaid is launched, there is such an increase in cost that there is real genuine fear among those who support the program that the cost pressure may lead to reduction of services. And we start to see, in fact, the federal government and the states beginning to ratchet back the rate of increase in Medicaid. And so this effort looking at other alternative forms of delivery and payment was an effort to find cost control and continue with the benefits and even expand them. Now, Scott, you're a student nationally as well as in Minnesota for the various forms that this managed care development occurred. Could you talk about some of the different models of managed care that we've seen here in Minnesota, but also around the country?
Sure, Larry. Minnesota is not fully unique, but somewhat unique in the fact that traditionally, although this has changed, traditionally Minnesota had a nonprofit health maintenance organization model. So the managed care plans that were operating in Medicaid were nonprofit plans, which was different than what we saw around the country. I know that's changed in the last several years, but still predominantly the vast majority of the enrollment is done through health maintenance organizations that are nonprofit by their status, which carries a little bit different sort of charter in terms of their corporate responsibility. The other thing that Minnesota operates is the county-based purchasing plans, and those sort of came up alongside the expansion of Medicaid managed care in Minnesota. As Andy mentioned, Medicaid managed care started regionally in Minnesota and small, and then expanded over time to encompass all the counties in the state. And as that developed, there was an interest among certain counties. It's a voluntary program among certain counties in actually operating their own managed care plans. And there's a number of them around the state that have chosen to do so, either individual counties or groups of counties. And essentially, they operate a managed care plan. It is county run, they receive the same capitation rates, and they're offered as an option in the state or in the county in which they operate, alongside some of the licensed health maintenance organizations that might also operate there. The difference I would say between what I see in Minnesota, or traditionally seen in Minnesota, and what we see nationally is that Minnesota does have less of a predominance of some of the larger national managed care organizations that operate in a number of other states. I know that Andy mentioned that 41, give or take, I guess, well, you would know specifically 41 states operate now managed care Medicaid. And what you typically see in those states are a lot of very large national players who come in. There are some regional plans, don't get me wrong, but that's what you tend to see more nationally. Minnesota's marketplace hasn't developed quite that way. We'll have to see what happens over time. There's some legacy enrollment in the plans that exist in the state. So we'll have to see how that changes or if that changes over time. But those are some areas that I see in terms of where there are different types of models.
How are these managed care organizations performing? Andy, you've kind of looked around the country. We went into the managed care approach as a way to control costs while maintaining benefits. How's it going?
So that's an excellent question, Larry. I wish I could answer it. So let me just start with, I work at the McCourt School of Public Policy inside a research center called the Center for Children and Families. And we're funded by private foundations to do research on coverage of healthcare coverage for children, and particularly low-income children, which means doing a lot of work on Medicaid and the CHIP program. Okay, so that's the way I'm looking at this issue. And most of our work right now is focused on making sure that the children who are enrolled in Medicaid, which is like roughly 35 million, 85% of whom are all in managed care organization arrangements, we'd like to keep them enrolled in Medicaid. That's a separate problem right now. But once they're in, we'd like to make sure that the managed care plans in which they're enrolled are performing for them. And you can have the same conversation with other populations enrolled in these managed care organizations, whether it's individuals with disabilities, adults without children, pregnant women, on and on and on. But just for kids, we've looked in some detail at a number of states to try to figure out the answer to this question. How are the plans performing for the children enrolled in those states? And the answer is we can't tell in most of the states that we looked. It's from the publicly available information on the state websites. And for reasons we'll get into later, that's an independent concern. But I can't answer your question now. We don't know which plans are doing the best in each state. And the state administrators know, the plans know, and possibly the federal agency that oversees Medicaid, the Center for Medicare and Medicaid Services, knows, but we don't, and we tried to find out.
So your work has been focused on the kids,
On children and families, that's right.
Which is key part of this.
Yep.
But overall, some of the research has suggested an impact in moderating costs. Modestly, I wouldn't overstate it. Scott, is that your understanding of kind of the national picture?
Yeah, I think there's a couple things that are important here. One is that, as Andy alluded to, from a state budgetary perspective, the predictability of the capitation payments that are paid each month from the state to the health plans does bring in an element of predictability. The rates that are set for those capitation rates have to be what are called actuarially sound, which means they have to at least keep up with the cost of the care that's being delivered underneath it. But what the moving to the capitation system over time has resulted in is not only that predictability, but also an ability for the plans and the state to negotiate rates that are reasonable, and underneath that are able to bring in the cost containment pieces. And what a number of states have done, particularly in the last decade or so, have been, I keep referring back to Andy because he did such a great job of laying the framework or the groundwork. If you looked 15 years ago, states had started to move to managed care. The states were paying health plans capitation payments, but underneath that, the payments that were going from the health plans out to providers were largely being done on a fee-for-service basis. What's changed in the last decade or so is a lot of states now have started to say, hey, we'd like to have you all managed care organizations work with the providers in your networks and put in place value-based payment programs that start to incentivize higher quality, lower cost care. And that's where you're starting to see some real impact around cost containment. So from an overall state perspective, you're getting better cost containment or better cost control as a result of the predictability of the budget for the capitation rate. And underneath that, the managed care organizations are then negotiating these value-based payment contracts with providers. And that has added a separate element of both what we believe in the work that we've done brings better quality outcomes, but also a little bit lower costs as a result of that as well.
Thank you. That's very helpful. Andy, one of the concerns during the early period we were talking about, where the federal and state government started to ratchet down the spending and expenditures of Medicaid, was that it might have an impact on access. What's been our record in terms of providers taking on Medicaid patients? Is that a good deal for providers, particularly as costs and reimbursements have gone down?
So, can I answer that by just jumping on top of the point Scott just made? So at the level of granularity he's talking about, that is where it really becomes clear it's a federal state program, and what's going on in a particular state and how it's dealing with its managed care plans. There's so much variation, and people are at different stages of evolution throughout. So I personally am not comfortable with like broad national generalizations, because there's just too much variation. And I'll give you the same answer here. In some states, provider participation, at least for providers of services to children and families, is not good. Just not, whether it's managed care or fee for service, because the rates are too low. And there are a lot of issues in the workforce now, as I don't have to tell a lot of people here. There are shortages in pediatric specialties. Depending on the state, there are shortages in primary care capacity. None of that is helped by paying providers less than Medicare would pay them for a similar service. And Medicare has its own issues about provider participation. So I would say, as a broad generalization to be used as a framework for what's going on in my state, underpayment is a problem, and it has not helped provider participation. I think some plans have been successful in improving provider participation because they have room, as mentioned here, to set up value-based payment arrangements or other incentives inside of the money that's flowing to them through the monthly capitation. They have room to negotiate more favorable arrangements with their providers than they would receive under the state fee schedules. But that's about as much as I can say. You really have to look at what's going on in a particular state.
Scott, you've been doing a lot of work in states, and I want to see if we can draw on that expertise to address the question that's come up here at the Capitol. Representative Tina Liebling asked at a recent hearing in December about how we're spending the Medicaid money, which it's the second largest expenditure in Minnesota after elementary and secondary education. So this is a lot of cash. And Representative Liebling is saying she wants to know how we're spending the money and whether we're getting what we should be getting for this critical area. What can you tell us based on the work you've been doing in states and looking at opportunities to innovate?
That's a good and broad question, and I'll do my best to shed a little bit of light on it. I thought I saw Representative Lee come in. Yeah. Question was asked. So a few things, Larry, that I would say. One is that I think it's a very fair question for policymakers to be asking, which is, we spend literally billions of dollars on this program. It's one of, as you mentioned, one of the largest, in some states, the largest program that the state operates. And when there's B's involved as opposed to M's, those are very important accountability questions to ask. So I want to sort of ground it in that those are the right and important questions to be asked here. One of the things that we see around the country is that as much progress as we've made collectively in collecting information and making it available to the public, there still is a lack of accountability, a lack of transparency when we look around at a lot of other states in terms of how much is, we know how much is being spent, where the dollars are flowing, and what the outcomes are getting for those things is not as transparent as you would like it to be. I think that's a fair statement. One of the first things that we did in Minnesota back when I was had the opportunity to be a part of the Medicaid program, we created a Medicaid transparency website that was really about putting out the state's contracts with the managed care organizations, putting in one place all the collective quality reports that would indicate how well the managed care organizations were doing on meeting quality outcomes. We put out all the information on what the budgets were for the Medicaid program and where spending was flowing underneath that, and a range of other things that would be important for anyone looking to see as much information as they could find about the outcomes and the costs that we see under Medicaid. But unfortunately, when we look around the country, we just don't see that being replicated in a lot of other areas. And if you're a person who's really into it and really wants to spend the time digging into it, you can sometimes find federal reports are doing it, or you can request it from states, but oftentimes those are not very readily available. I think Minnesota's done a really great job in that sphere. So this is the states should feel lucky that I think the agencies have tried to be pretty responsive about getting good information out about to the question, what are we spending our money on, and what are our outcomes what kind of outcomes are we getting for that? Doesn't mean more progress can't be made on that, and that's certainly the case. But I would say that on a relative basis, Minnesota does pretty well.
Andy, I know you worked on and thought about transparency for a while. Where do you think we are nationally? If you could situate Minnesota in that cross-state comparison, would be helpful.
I would love to do that. So just a shout out for Scott and his website in 2011, way ahead of the curve. And I've seriously scrubbed 17 state websites, right? I mean, like we have looked everywhere on those, and there's nothing comparable to what you started. So kudos for that. So nationally, I haven't been through all the state websites. We're working on it, but haven't been there yet. I don't think, based on the research we've done so far, that there's much transparency as a general rule. It's not a definitive conclusion, but if you look at some of our reports, I think you'll see there, and we're just looking for children and families data. It's very, very difficult to get to. And that, is a disappointment. This is a public program. It's funded by federal and state taxpayers. The performance of the contractors, in this case, the managed care organizations, that should be a matter of public record, and getting plan specific, very, very difficult. I won't just beat up on the states. I'll also beat up on the federal government, because CMS could do much better on the transparency front as well. And we don't have time to go into the details, but their website could take some lessons from what Scott did in 2011.
Yeah. So this is a critical issue. It's good to hear Minnesota was out front a dozen years ago, and it sounds like still doing better than other states. But Scott, you've been working with states on the value-based payment reforms, issues around equity. Could you talk a little bit about that? Because I think for people who are frustrated and, like Representative Liebling, want to know what people are getting for their money, some of that work seems relevant.
Yeah. So I would say that one of the things that states have increasingly done is, so when you think about kind of the structure of a state Medicaid program, you have the Medicaid agency running the program, and then you have all the providers who are delivering services, the enrollees who are coming from a variety of different backgrounds, some disabled, moms and kids, and just a bunch of different types of populations. All of those populations have different needs. And the state, in 41 cases, has chosen to contract with managed care organizations to ensure delivery of services to those enrollees. But states, I think, are really innovating a lot in a variety of different spaces. So some of the work that we've been doing in working with states and managed care organizations, we were funded in the last couple of years by the Robert Wood Johnson Foundation to establish what's called NORC's Medicaid Managed Care Organization Learning Hub. And we work with plans around the country and Medicaid programs and enrollee advocates and the advocacy community and community-based organizations to help to look for ways in which MCOs or managed care organizations that are operating in the Medicaid space, meaning that they're contracting with state Medicaid programs to deliver those services, those needs for people who have a variety of different ones, to really partner with community-based organizations to bring some of the other services that folks might need in addition to the direct healthcare. So that might be food security, that might be housing security, or a range of different things. You can think about what are often called the social drivers or the social determinants of health, right? And so that is increasingly an area that a lot of states are very interested in. And how do we encourage and support partnerships between managed care organizations who are operating in our Medicaid program and getting it back down to the community where the folks live to ensure that they're getting the services that are going to keep them from actually hitting the healthcare system in the first place. A lot of emphasis on that. The second area I've already referenced, but I'll just briefly mention it again, is in the area of value-based payment. And actually those things align. So if you think about value-based payment, if a provider organization is receiving, is in a accountable care organization type of model where they have some risk and accountability for the costs, so not a pure fee-for-service system that like Andy was describing, that provider system now has an incentive as well to help to think about upstream, how do I, if I'm going to be accountable for both the health and cost outcomes of the population that I'm serving as a provider under that payment that I'm receiving from a managed care organization, what incentive do I have now to actually hook a person up with food services if they need it, help them find stable housing, a variety of. Hennepin Health was a great example in Minnesota, for example, back 15 years ago when they started to think about how do we're serving really low income populations, how do we start to really ensure that they're getting some of those social needs met. So states are really looking at that. And I have to say that our snapshot, we're not talking about just blue states here or purple states. It's across the board because the needs of people, regardless of the political culture in a given state, are still there, and Medicaid programs are recognizing that. And tying it back to managed care organizations, and then I'll stop, Larry, is that has been a focal point for them. They have this single point of payment where they're making the capitation rate payment out to the managed care organizations. They can then work with those MCOs to help develop what that web looks like of services that are beyond the medical sphere. What do those partnerships for community-based organizations and others look like? So that's a number of areas where we're seeing some real interesting innovations at the state level.
Good. So it's not just the same old thing. There's quite a bit of dynamism here. Andy, a question from the audience. Do we see significant differences in the way nonprofit and for-profit insurers administer Medicaid?
If I could tell how anyone would do it. That can't. So, when I was even younger than Scott, which was a long time ago, I would think in terms of for-profit, not-for-profit, public. I don't think that way anymore. But to me, it's all about performance. Yes, there are within a nonprofit, for-profit. The incentives are a little bit different for each of them, but ultimately, what Medicaid is paying for and should be paying for is we need performance for the populations enrolled, right? And I personally don't care whether it's a for-profit or a not-for-profit or a public organization. I need to see performance for the enrollees. And by performance, I mean access to the benefits that they're entitled to and that they need, and at a reasonable quality, a robust provider network, so you can get that access on and on and on. So it's just the best answer I can give you. I don't, there may be data out there. You know, it's possible the plans have it or research organizations like Scott's have it, but I can't see it from the work we've been doing.
So Scott, let me just ask the most basic question. For a for-profit insurer, they've got shareholders, right? And they've got a market, they've got a need. The nonprofits and the publics don't have that same dynamic. It's not to say there's not pressure on them. There is. For states where we have the data, where there is some level of information, does that show up? Do we see, you know, less denial of care? Do we see, you know, something in the behavior in terms of, you know, the regulation, the prior authorizations? What can you tell us?
Yeah, it's a good question, and as Andy has already alluded to, you know, the fact is, if you've seen one Medicaid program, you've seen one Medicaid program, and so it varies again by state. What I would say is that we certainly are seeing, and Congress is starting to pay attention to this issue of prior authorization and the need to get approval for a service before you can deliver it to, as a provider, approval for a service before you can deliver it to a patient. That's undercoming greater scrutiny. I think a lot of it ties back to two things. One is, how well do the states manage and oversee the managed care contracts that they have, and how do they, you know, intervene when they see things that aren't looking good within those, within the way that the plan is operating on their behalf with the patients that they're seeing. And we see variation around that, and I would say that there are certainly cases in other states where you see that to a greater degree than others. The concerns about access, for example. The second thing I would say, and one of the things that I always appreciated about operating in Minnesota, is that there was a degree of locality that was great here, meaning that the plans that are operating in Medicaid were local plans. They were all headquartered in Minnesota. If it was the county-based plans, they were the counties. So you knew how to find them and talk to them. And there's something about being able to actually know the people who are operating the health plan that you're operating to. I could pick up a phone and make a call to whomever I needed to within that plan construct to get to give them praise if I need to, or express concern. So there's an element there that I think varies around the country as well.
Okay, it's a pretty nuanced answer that you've both given. Andy, you know, we're talking about different ways to control costs. We haven't talked about probably the go-to option if Republicans gain control in Washington of one or, you know, the lawmaking branches altogether, which are block grants, which pulls away the federal entitlement, which we've been assuming during this conversation, and instead says to the states, we're going to give you this amount of money and go have fun with it. But that's it. We're just going to block grant you. We've seen that in the past. Do you think that's still an option? And as we talk about Medicaid in different directions, should that be on our radar as well?
It should be on your radar depending on the results of the election in the fall. So I should preface this. I am a Democrat, and I was a political appointee during the Obama administration.
But quite apart from the
Just so, well, it's hard to be apart from the partisanship, at least in DC. The idea of a block grant is, instead of open-ended federal matching, state expenditures for covered services for eligible people, state gets a certain amount. It knows in advance what it's going to get, and that's what it has to play with. Okay. And from the federal government standpoint, if you're just looking at the federal budget, which has its problems, as you know, it's very attractive because Medicaid is such a large expenditure. It's over $500 billion federally this year. And so, of course, constraining from a base that high, constraining growth over the next 5 or 10 or 15 years by limiting what you are going to give each state, that can generate a lot of savings for you. We'll get back to the problems in a second. So this was first tried in 1981 by then President Reagan. It was tried again by Speaker Gingrich in 1995, and it was tried again by President Trump in 2017, and all three times was rejected. So there's sort of a pattern there, if Republicans come in and they're looking for budget savings, they'll go to Medicaid because there's a lot of money there, and half the program is kids and they don't vote. So they'll, my view is if the Republicans take over the executive branch, that will be one of their initial budget proposals. And again, a great deal for the federal government, particularly given the demographics involved here. I'm the bow wave of the baby boomers, and we are expensive as a group, and we're not going to get any cheaper as healthcare costs increase and as new medications are developed and put on the market, on and on. It's going to be difficult. States will have to manage that, and under a block grant, they'll have to manage it with less money than they need by definition, right? And of course, that sets up a whole range of very difficult rationing choices at the state level.
I want to thank everybody, including our friends online. We have got a large stack of questions and pages of questions, and we're going to have to stop it there because we've run out of time. I want to thank Scott and Andy for coming to Minnesota and for this terrific conversation. If you're interested, they've got a ton of stuff online. They're both prolific and widely used by all sorts of health policy people. So thanks for the work you're doing. I want to now transition to the next panel, which will look at a debate in Minnesota Capitol.
So thanks. This is part two. Let's see. So who am I? My name is Chris Snowbeck, and I'm a reporter at the Star Tribune. I've been covering healthcare stories for about 30 years, and I'm still hanging in there. So today's panel, the second half of the panel, and I want to say the first part was just great, I thought. And so we're going to try to now sort of bring it closer to home and talk about kind of the debates about surrounding the role of managed care organizations here at the Minnesota State Capitol. And as an aside, I mean, so one of the things, I'm kind of from here, and I came back to the state in 2006. And one of the things that I think is super interesting about Minnesota as a place to write about managed care is, as I think some of as Andy Schneider's comments reflected, I mean, this is a state that was, very innovative. And to this date, like with United Health Group and the nonprofits, I mean, they're big names nationally in managed care here. I will say, though, that as someone who writes about the sector, I'm a business reporter, we have other sort of corporate innovators, like with pacemakers and Post-it notes, that where I think there's more immediate, rah booster sentiment. And managed care is I dare say it's a more complicated sentiment that people have about managed care. And that's part of why I'm interested in talking with our panelists about Minnesota, because, it's a really lively and important debate with really sophisticated people, I think, on all sides of it right here. So anyways, so today we have Representative Robert Bierman and Representative Ann New Brindley. So Robert's all the way over there. Robert is a Democrat serving District 56A, which includes Apple Valley. He was first elected in 2018 and is serving his third term. He's a small business owner, continuing a family business that was established over 100 years ago. Bierman is the vice chair of the Health, Finance, and Policy Committee and serves on the Climate and Energy Finance and Policy Committee and some other committees. I'll just leave it at. He currently lives in Apple Valley with his wife and 2 children. So Robert, thanks for being here. Appreciate it. And let me turn the page. So Representative Ann New Brindley is a Republican who has served District 28B in the Minnesota House of Representatives, representing Chisago County since 2017. Prior to being elected to the House, she served on the North Branch Planning Commission. She is the Republican lead on the Human Services Finance Committee and also sits on the Commerce, Finance, and Policy and Health Finance Committees. She lives in North Branch, where she's lived for 10 years with her 5 children. So, Ann, thank you for being here also. Where I thought we could start is, as I sort of said in my little rambling preamble there, I mean, managed care is, a lot of people in Minnesota know a lot about managed care and have strong feelings about it, pro and con. And so, Representative Bierman, I mean, when you think about the debate at the Capitol, I'm going to change the script here a little bit. We were talking last night about some questions, but I want to start just generally with both of you. Like, what, Representative Bierman, what are the big debate points about managed care as you see it at the State House going into this session?
I think one of the big debate points is that managed care has been in Minnesota 30, almost 42 years. And the ability of legislators to look at managed care and, as we heard from our presenters before, to understand whether it is meeting all the reasons it was created, which was to extend access, quality, and most of all, reduce costs. And so people would like to see the evidence of that. As we heard, it's difficult to find. And so I think there's just sort of an initial thought, after this much time and where we are headed with unsustainable healthcare costs, which is affecting everything about our economy, that, we just need to have a fresh look at it and keep an open mind and do a study and determine what our options are in Minnesota to pursue healthcare that will be innovative, as this was when it started. And so, that's kind of, I guess, in a nutshell, kind of the bigger thought and vision of policymakers and, I think, constituents too.
So this is a really interesting question. And I think, as you indicated in framing your question, that folks are familiar with managed care. And I don't know that folks really are familiar with managed care. They are familiar with insurance companies and how insurance works. And I think there's a real rub for a lot of folks, sort of this moral and ethical question of, should they be allowed to make any profit in this space? And I think that a lot of this conversation sort of focuses on that. I think that when we have talked about this at the Capitol, we have sometimes focused a little bit too much on managed care as a payment mechanism, and maybe not quite enough on managed care as a care delivery mechanism, the coordination of care, the requirement of managed care to make sure that children are receiving their immunizations, and there's good prenatal and postnatal care and things like this. And there's actually financial incentive for HMOs to make sure that those things are happening. So it's not just a mechanism of how we pay the bills. There's more to it that I think folks don't know, which is part of the problem, I think.
Yeah, no, thank you for that. And so when as a reporter sort of covering the sector, and one thing that jumps out at me is I looked at the omnibus health bill that came out at the last session. And so there's a call for a study and an implementation plan that looks at maybe doing away with the private nonprofit. Well, I guess not just nonprofit. I guess the private insurers. It would preserve county-based organizations, but the insurers would no longer be in managed care. And this is a study. It's a ways out. but it's in there, and there's going to be debate over the next couple of years about this. And I guess I was curious, I mean, and we'll start with you, Ann, first. I mean, when you think about the track record of the managed care organizations, what kind of grade would you give it? I mean, have they done a good job? Are there things that you think they could do better on? How do you think about it?
That's a fair question, and as our previous panelists indicated, one that is difficult to answer. However, I think it is important to note that there are accountability measures in place for managed care organizations. Structurally, they answer to DHS. They answer to the Department of Human Services. The Department of Human Services is given information from insurers, from MCOs every other week. I mean, the department has a great deal of information to work with. And so presumably, when the department is renewing contracts with MCOs or creating new contracts with MCOs, they're taking that information into account and making sure that they are signing contracts with MCOs that are performing and that are providing what they say they are going to provide in those contracts. But again, it's presumably, we're also making a big assumption that DHS is doing their job in holding them accountable.
Yeah, Robert, what do you think about that? What grading or?
Yeah, I don't know that I would give it a grade either. It's hard when you don't have the information. And I think that's the point of this section in the omnibus bill, was to give us more information, have a fresh look at this other option. And in the meantime, we have a couple of years, if there's data out there that insurance companies have that they would provide as far as helping us understand it better, if that can come forward, that would be extremely helpful. We heard from the previous two speakers talking about them having to go in and scrub websites and try to gather the information. No, we need a better system than that to understand the success or the troubles of managed care organizations. I think that it's a very complex issue, that we don't go into this lightly, that we take some time to look at the data and to understand from what would a fee for service system look like? What are the advantages of that as far as comparing it to managed care organizations? Managed care organizations have been working here 40 years, and they've created a network that has been, helpful to many Minnesotans, and we have to give them credit for the work that they've done. And I would say too, even, lately, they've gone to the extent of going way beyond just medical care. We've all realized the social determinants of health and the issues of disparities exist, and they're focused on that, and they have their eye on it. But at the same time, the amount of cost associated with it and the profits we've seen recently, and we can talk about that as well. But, we just have to make sure that in a system where we are seeking care for the state of Minnesota and all the people who, especially in the managed care area, need that care coordination. It's been very uneven across the country. If you try to look at what managed care organizations have succeeded in doing, it's hard to gauge. We need better understanding of how they're doing here in Minnesota. I like the last part of that conversation where I think it was Scott was talking about that community-based needs assessment, which is something that hospitals have started to do or are required through the ACA. And I think seeing that with managed care organizations is fundamental to more innovation. And I appreciate that. But giving them a grade, I guess I would hesitate to do that. And there are a lot of issues that we as policymakers just need more information and understand it even more. I think the last thing I'll say is, the fact that managed care, or now we've heard more about the IHP being interfaced between doctors and patients, to me, that we had the explanation of how that can save money. But I think, the proof is in the pudding there too, as far as the data. And that's another layer between patient and doctor. And so I want to learn more about that too.
Got it. Thank you. Yeah. We've mentioned profit, and I'll confess I'm So I've covered healthcare a while, and sort of I think I've said this before when Larry's been nice enough to have me for one of these. I tend to think that, back on the point of transparency and the quality, and I mean, that's what really, I think, is paramount for all of us as we use healthcare. And yet it's also, I found it extremely difficult to systematically understand quality. And so in the course of my writing, like a dollar is an easier concept than quality. So just for a minute on the dollars, and just to kind of to emphasize what I think Scott and I recall saying in particular, I mean, these in the previous panel, I mean, the state puts a lot of money into managed Medicaid. I think I have my notes here, but the revenue to the plans, I need my glasses, I guess. Sorry. So the revenue to the plans in the most recent year, when I did the numbers, it was just over $10 billion. And there was significant profit in that most recent year of 2022. And profit can kind of ebb and flow. But I was just curious for both of you as kind of policymakers. I mean, we've heard about, we don't have transparency on a lot of the things that you might like to be able to look at, but people like me write stories about profit. So how do you think about profit in this sector? Are you concerned the state is not getting good value, or are you pretty comfortable with the expenditures thus far? I'll start with you, Robert, I guess, if you have a take on that.
Well, your article on that put the 687 million in the headline. So I went right to it. I wanted to read about that. So, I think that it's helpful to know the history of what that profit has been over years, and to see that Minnesota was slightly below average for a number of years. And then there were some years where profit was starting to rise, and then we hit COVID and it blew through the roof. And so there's a lot of reasons for that. But certainly it is something that, when you're a policymaker and you're looking at costs and you see a number like that, follow the money, and understand it first. And then we have to, understand the risk corridors and the clawbacks and the resetting of rates. All of that plays into it to kind of answer that question. But I mean, some comfort is given by, these HMOs are, for the most part, nonprofit, which means their revenue and their assets are paid for by taxpayers. And so that is another one of the things coming in this coming term, which we're talking about, is that HMO standard and guidelines, which is a part of last year's bill, which will come forward with a study. And moving forward, we'll have a preliminary in February, and then we'll move on to the final, like late in this session. But that issue of the HMO's role and how they operate here, we can look at that and say that profit needs to be a healthy margin so that they can cover their costs. In the past, HMOs have played a crucial role in putting money forward for providers and prepaying some things at times in healthcare needs through COVID, and when government shutdowns were imminent and there wasn't money flowing. That revenue is important, and they've used it in good ways at times. But it's important for us as taxpayers to know where that money is and how it will manifest in the future for the benefit of Minnesotans' health. And so that, I think, is a critical role at the Capitol this year, and one we'll be following closely.
What do you think, Ann? Yeah.
I think there are several pieces of this that we need to consider. Certainly, there are years that there are significant profits, but the benefit of using a managed care organization is the state negotiates a cost upfront, and that is the cost that they pay to MCOs, regardless of whether MCOs incur losses or profits. And so it is a way to mitigate risk for the state, that if for some reason there are very high costs that year, the state is not on the hook for those costs. And it also means that because the MCOs are assuming that level of risk, they also get to benefit from the profit if there's a good year. Now, that's also limited, which I think is a really important piece of this. There are medical loss ratios in place. There are sort of guideposts in place to ensure that MCOs don't just get to deny care and take everything as profit. They have to meet certain metrics, and I think that the number is 85%. They don't get to take that much profit. And in fact, if MCOs do earn too much profit in a year, there's a clawback by the state. That additional profit above that negotiated threshold goes back to the state. So there really are guardrails on that, so that the insurers, the MCOs, can't just operate in a way that allows for runaway profit. I think the other important piece of this, we talk about this, approximately $650 million number. I think we also have to consider, can the state do it more efficiently and more effectively and cheaper? And I think that's a real question to consider, because the state is not necessarily able to do that. It would require, if indeed we make a move to eliminating managed care organizations, that is a massive increase in state government, in the bureaucracy to support such a move, which comes with increased costs. That doesn't exist in a vacuum, of course. And there's also a real question of, is that even possible? You hear, it doesn't matter what sector it is, whether it's government, whether it's healthcare, whether it's manufacturing, we have a workforce crisis in this country and in our state. There are not enough bodies to fill these jobs. And so there's really a good possibility that even if we did eliminate managed care organizations, we would still have to contract with them for services. They would still probably serve as a third party delivery for this payment mechanism. So again, there are guardrails in place, and there's a big assumption if we are assuming that if the insurance companies don't get these profits, that the state will be able to do it for less. I think that's a big assumption that is maybe premature in thinking that would be the case.
Yeah, well, thank you both. And, in the previous session, there were a couple terms thrown out, value-based care and accountable care organizations, and which I hesitate to define those terms. I think I know what they mean, but I mostly am just annoyed by those terms because it's yet another way that talking about this sector that is really about all of us patients, right, becomes this thing that we can't even. Anyways, so having said that, let's just say at a high level, value-based care and accountable care organizations are kind of about maybe alternatives or new ways of doing things that maybe would be a different approach than the managed care that we have. And I'm curious for each of you, like, are there new structures that you think really are promising that could give the state and Medicaid beneficiaries better outcomes? I'll start with you, Anne, I guess. I don't know.
That's an interesting question. And, we have discussed that there are very few of us probably at the Capitol who even have interest in understanding these issues. As it turns out, most people are not running towards these committees and digging into these things. And because of that, we often are dealing with what is in front of us instead of what is possible, which is really unfortunate, actually. And so I would suggest that I think that all of us would be very open to innovation. I think all of us want the best delivery for the lowest cost with the best outcomes for Minnesotans. That's what we want. That's what we're looking for. And right now, I'm not sure that there's consensus around what that looks like. I certainly have my opinions based on what's before us right now. But I'm not sure we really have a good sense of the art of the possible on that, of is there really a viable alternative? If it's there, it hasn't been presented in a compelling way.
Interesting. Robert, what do you think?
I liked a lot of what Rep. New Brindley just said, and I appreciate the fact that she is open to this conversation and the thoughts, and that's what we're going to need is some bipartisanship on that aspect of it. When I think about healthcare, though, I think that there's, not just members at the House, but when I walk around my district and talk to people about healthcare, most people have issues with our current healthcare system. I met some small business owners just yesterday online and 24 of them, in fact, and listening to them, I heard the same thing that I deal with in my small business, and that impact of a healthcare system that leaves a lot to be desired. And I think there is a search for what that means and what else we could do. So, and speaking in the grand healthcare system, that's maybe a different Humphrey School issue. Happy to come back and listen to your speakers again and talk or sit out there. But I think that, that consensus is that people understand we need to make changes in our healthcare system in this country. And it's not, Medicaid is just one small, although very complex portion of that. And so we do need to do our due diligence on it and understand, how that relates to individuals, the budget, the whole schematic. But I think people are definitely willing to talk about it, and we just need to be brave enough to understand that there are other options. And just because we've had this in place for 30 or 40 years doesn't mean we can't make some changes to it and seek those, costs that we can sustain in a better way. And most importantly, get the better health outcomes that we should be getting for the amount of money we are spending on healthcare in this country.
Let me add something to that really quickly. I think that's interesting that, as you indicated, I suspect anyone in this room will say that when we talk to folks, people are frustrated with the healthcare system. I, however, take a little different approach to that. I think we are in a situation where our healthcare system has been vilified often, because when it is difficult, when we do have to deal with an issue, it is a real challenge. And we have to face that challenge typically when we are in a circumstance where we just need care. I was dealing with this with a family member recently, and she was very frustrated over an issue because she's in a different state, et cetera. And so it adds a layer of complication. And I just said, you know what, though? The vast majority of time, the system works as it's supposed to. You go to the doctor, you have an appointment, your insurance pays for that appointment, and it works as it is supposed to. The problem is that 5% of the time where it doesn't, it's extraordinarily frustrating. But I think that because of that, it's a little bit of a misconception, actually. I think that this system is totally broken and we need an overhaul of the whole system. Well, there are certainly some things that should be tweaked, but the vast majority of the time, the system works like it's supposed to.
Okay, we're into another conversation.
I'm good at that.
And I would like to chime in, and there's a lot I could say, but I think just to acknowledge that our healthcare system in the United States has some really strong points. One of them being right here on this campus, the University of Minnesota Medical School, and the innovation that we see right here in Minnesota. It makes it a destination for people who want to do research in so many areas. We are lucky to have it, and we need to continue to support it. So that's one thing. On the other side of that is healthcare. If you talk to people you go abroad and talk to people about their healthcare, or talk to them when they come here. Our healthcare system is the envy of the world nowhere. So I mean, that's my understanding and, you know, you might get to some people who say, well, in Canada, we have long waits. You know, you have waits here too. It's a different system for sure. I just look abroad and I see places like Japan, completely different situation. They live longer than anybody else. They go to the doctor more than anybody else. And so our system, we just need to have more transparency, take down barriers, get people the care they need when they need it. So we will have a healthier population that lives longer, which is not what's happening in the United States.
Let me go to some of the great questions we're getting. Let's see. So from the audience, I should say, one of the challenges, one writes, one of the challenges I have seen over the years at the Capitol is an inability of the current fiscal note system process to project accurate or any cost savings with new or innovative approaches. Could the data we get from MCOs, managed care organizations, the insurers, and county groups, and other sources provide an ability to capture cost savings so legislators are able to make more informed decisions on new bills and spending? I'm curious, I guess I'm losing track of who, I think we start with Robert this time, but what about that idea that, you know, as you as a lawmaker, do you find that the fiscal notes that lawmakers get to estimate the finances of all this, that you just aren't getting what you need? I don't know.
So I'm only in my third term, so I can't really speak maybe in depth of others, but I have had instances where fiscal notes have come back and, you know, I have had questions about them and over time, you know, you can get a new fiscal note too and different data. And so that's a great question and one I will take up with me on Monday when I meet with DHS, and I will ask them that question. But I mean, I think there is some variation and people complain about the fiscal notes they get in light of the bill they're carrying sometimes. And there's, you know, we don't have an ability to assume cost savings. With the dental organization, for instance, I was working on periodontal care a couple of years ago, and then with the full Medicaid adult dental set, which just took effect this month, they weren't able to, you couldn't bank the savings that you were going to have from the lower rates of emergency room care. That kind of scoring isn't available. So I think there's some problems with the fiscal note system when you can't look at data and say, this is what it costs us. We do this, we're going to have a large measure of savings to factor in. Dynamic scoring, that's what they call it. We don't get to do that.
Anne, what do you think?
So specifically, I think your question specifically was, can MCOs provide additional data that would help in the accuracy of fiscal notes? So interestingly, the way this process works, when a fiscal note is requested on a particular bill, the Legislative Budget Office goes and does their best to track down the information they need to estimate either the additional costs or the cost savings. And in doing so, they go to the Department of Human Services, and DHS provides the information that they need to construct that fiscal note. And again, you know, I mean, maybe I alluded to it. I don't know if I said it specifically, but DHS actually does get a ton of data from MCOs every other week. So the insurance companies are required to report this data to the Department of Human Services very regularly, like I said, every other week. And so presumably, while, I mean, there are sort of proprietary reasons that this information, this data is not widely available to the public, the Department of Human Services has a ton of data that they can use then to direct, to inform these fiscal notes as they are written. The other thing that I would say is that sometimes it can be hard to quantify cost savings, but it can also be difficult to quantify additional costs, things that we can't add additional costs for. I mean, for example, you know, while yes, in the omnibus bill, we ended up with a study on eliminating managed care in the state of Minnesota as part of the fiscal note. However, I should say, the bill that went through the legislative process was not on a study. It was actually to eliminate managed care. And so that's the bill we heard throughout the legislative session, was to actually eliminate managed care. Thankfully, and I think it was prudent that that became a study instead of legislation. I think legislation is definitely premature. But as part of the fiscal note on that bill, it's noted that they can't quantify the cost of care coordination. They can't quantify that, because right now, as I said earlier, MCOs are required to provide care coordination, to make sure that children are receiving immunizations, that women are receiving pre and postnatal care. I mean, these kinds of things are part of what MCOs provide. That is not accounted for in that fiscal note, but is a clear cost. So it happens on both sides of that equation.
Interesting. I think the note said 5 more minutes. Is that what? Yeah, right, thanks. Let me go to this question, and we'll try to get one other in as well. Minnesota Medicaid MCOs all use for-profit pharmacy benefit managers to pay for prescription drugs. These PBMs systematically kill and close pharmacies in Minnesota. And this some towns that have lost pharmacies. Why does the state empower these PBMs via Medicaid only to see them close pharmacies in the state? Anne, what do you think?
We just opened up an entirely different panel. I think that this is a critical question. I think the supply chain for pharmaceuticals is at least as complicated as Medicaid delivery. It is extraordinarily complicated and has evolved over time, and includes these pharmacy benefit managers that act as sort of the middlemen between the pharmaceutical manufacturers and patients, providers, et cetera, to deliver pharmaceuticals. There's a lot of controversy over PBMs, and I suspect we would have a lot of agreement over the problems with PBMs. I actually have a lot of frustration in that it is easier to go after pharmaceutical manufacturers. And so that's what's happened in Minnesota over the last couple of years, is we've gone after the manufacturers. I think it's a little problematic to go over the folks who are actually producing something and creating something and researching and developing life-saving cures, rather than really choosing to dig into the very complex supply chain that includes PBMs. I think it's a little lazy to go after just the manufacturers. We need to discuss this PBM issue. And I think that is all I can say on that for now. It really is incredibly complex. But PBMs probably need to be looked at much more closely, and how we are delivering pharmaceuticals.
Robert.
Yeah, I mean, I agree with a lot of what Representative Brindley said. That is an issue that since I came to the legislature, there had been a PBM bill that we finally did get passed, but it's never enough. And so these organizations, we have to look at maybe some other options too, and consider, a new state purchasing method where we're using, perhaps just a PBM, and looking at the value chain of pharmaceuticals. There's a lot of talk about importing from other countries and trying to lower costs any way we can. I think the pharmaceutical task force in my first year in 2019, their number one issue was an affordability commission, which finally passed, but it doesn't address branded drugs. So there's a lot of work to do in this area.
I'll ask one last thing real quick. I think we're almost done. In 10 seconds, you get transparency on one thing. What from our managed Medicaid system? What do you get transparency on? What would you like? Robert, we'll start with you.
I think transparency on prior authorizations.
Ann, 10 seconds.
I think we probably, especially with the entrance of for-profit companies, I think it would be good to have a handle on claims denials, sort of
Interesting.
associated with prior authorization, but
There's
we can
bipartisan
understand.
agreement. Interesting. Okay.
Demand on that.
So I'm Chris. I think I hand it now to Larry Jacobs, who we are all indebted to. So, but thank you, Ann and Robert, and thank you, Larry.
Great panel. I want to thank Chris Snowback, who is our state's healthcare reporter. We all rely on you a lot, Chris, so I don't want to put pressure on you, but and two wonderful state legislators. Thank you. Now I want to tell you who we're really indebted to. One is Cody Jackett, who's working quietly in the back, but he's the one who lined up today's program, and it is work. So thank you, Cody. And Lee Chittenden, who's our captain. Thank you very much, Lee and Cody. I've got some very quick announcements and then some cheery news, particularly for those of us here. First, I want to thank again Blue Cross Blue Shield for sponsoring this program. We are a dozen years into this. We've had Democrats, Republicans. We've talked about payment reform, single payer, Medicaid, delivery, and other topics. And it's, I think, been a powerful and helpful series, and we're thankful. So thank you very much. I want to just mention some of the programs we've got coming up. We've got the series on the 2024 elections. We've just started it, and I think it's really terrific. We've got Lisa Dish coming in early mid, I guess, February. She is a well-known, kind of nationally distinctive political theorist, Democratic theorist at Michigan, and she was elected to the city council in Ann Arbor. And you will get a lot from hearing from Lisa about the health of American democracy. We are seeing some very significant ways in which science is being shaped by politics. We've got a great program coming up in March on that. In April, Senator Rob Portman is going to be visiting us as part of our Nagasaki Dialogue series. He's going to be talking about how we work together across party lines. And then later that month, we've got a program on women, the 2024 election. And Anna Greenberg, well-known political consultant, will be with us. Also, we're working, haven't quite finalized programs as part of our Conservative Voices series that I've been working on with Vin Weber. We've got Kevin Hassett, who's a very well-known economist. He publishes in economics, the American Economics Review, and he was Donald Trump's head of his Council of Economic Advisors. The guy is just brilliant. I always love talking to him. He's coming this spring. Stephen Hadley, who was George W. Bush's national security advisor, will be here probably in the summer. Very important figure in national security, which tends not to be partisan. And Mr. Hadley will be talking about some of the really big challenges that America is facing. Finally, I just want to mention briefly, if you enjoyed this program, it will be a video recording of it posted in a day or two. There'll also be a podcast. Please feel free to share it with folks. We usually are now getting, pretty large numbers of people passing these around, and we welcome that. If you're able and you enjoyed this event, please consider making a contribution. Our programs are open to everybody, and we rely on support for it. Finally, here's the bright news for those of us here. There's food. There's food and drinks, and so we can kind of hang around and continue the conversation. Thank you very much for joining us.